Good afternoon, everyone. My name is Lisa Nelson, and I'm here today to talk to you about integration between public health and clinical care. The profile that I'm working, I'm a profile author for IHE. My background is in computer science. I also have an MBA and a master's in medical informatics. And so that gives me the qualifications to be the writer of one of these profiles that becomes an IHE specification. My goal today is to not only tell you a little bit about this early hearing detection and intervention workflow profile, so you get a sense of what that's doing, but also to give you a glimpse of what it's like to write one of these profiles if you're participating in IHE. Hopefully many of you will take your own use cases and think, wow, this is an avenue that I could use to bring forth a standard or a specification to help with the technical problem that we're facing. And so I'll give you a little bit of a glimpse of how you can make that happen using IHE's processes. I wanted to say to begin with that the IHE process is an 18-month process in the best case scenario from when you get started to when you really bring a profile to be tested. So there's a long phase where you're looking at, the gentleman who spoke before me is in an early phase. First writing that profile, you then have to take it to public comment to receive feedback, get it ready for technical implementation. Someone finally decides, or several systems pick up your actors and implement those, and about 18 months later, a profile is ready for testing. It's a big commitment. My client, who I work for, is the Public Health Data Standards Consortium in the United States, and that's an organization that's a group of different public health organizations that come together to jointly work on profiles that help advance public health. And so they came with a partner from the CDC who was working on the early hearing detection and intervention program. They had a big goal in mind. They saw that there were problems with children who were being born and not being tested for hearing loss. And then as a consequence, care that could have been provided that would have made a very significant impact in their lives and in the cost of subsequent care was being missed. And so they saw the possibility to improve the functioning of the systems and the interoperability of the data that passes through the care process to facilitate this public health goal of having all children have their hearing screening before they're discharged from the hospital. Now, they came to us with this big mission, and they had identified 5 use cases. They knew that they wanted the technology to be able to help them handle newborn hearing screening. They knew that it needed to handle the normal case where the screening results were fine and no risk factors were identified, but they also needed to know that it would work when either the screening did not get performed or when it was performed and it indicated that a referral was needed or some further care. They also had the goal of being able to do these short-term care follow-ups, kind of this ongoing management aspect of being able to look after the child over a period of time to make sure that the intervention was really helping. And then, of course, to have the surveillance over the program as a whole to make sure that the feedback and the guidelines that they were putting back into the care cycle reflected what they learned from doing this. So this was about 4 years ago. This was a big goal. So IHE sent them to a domain called QURF. We pronounce it QURF. It stands for Quality, Research, and Public Health. And it's an odd sort of combination of disciplines, but what we found from a technical point of view, that many of the workflows, many of the system capabilities that you need to support clinical research are really very similar to what you need to support public health and quality management. In fact, in the United States, there's even an initiative that's starting to look at how to minimize the number of standards that are involved in these different domains so that we have some efficiency to be able to utilize the same kinds of data represented in similar ways and really simplify this even a little bit further because there are great similarities here. So the core domain in IHE had a lot of experience looking at profiles like this, and the first thing that they said is, this profile is way too big. If you're going to develop technical specifications, it's a very precise thing that you need to do. Every piece needs to be specified, and there's some big gaps that we see right now with what you're hoping to do. There's parts of the picture that simply are not filled in. So, you know, good luck automating the workflow because you have to kind of take some steps back and build some earlier parts. And so the group worked over the past 3 years to clearly define a content document, for example, that would represent that early hearing care plan. It's a CDA document, it has certain needed sections in it, and it can represent the care plan that's needed. There were communication gaps between the EDI program management and the birthing facility, where we couldn't really know if we could calculate some of the necessary measures which require a population of newborns to be studied, because we didn't know what the population of newborns was. We only got results of newborns that had their hearing screened. And if newborns didn't have their hearing screened, they never got the report, and so it was impossible to really determine what the population was. So we ran into this technical challenge. We had to step back and invent another profile that's called we call it NANI, the Newborn Admission Notification Information. So we solved that technical problem of how does a birthing facility really communicate downstream that a child's been born, so that we then know to be ready to measure and to count whether or not the screening has been done. Then there was the whole problem of how do you actually do the quality measurement. And that took us down another long tangent to get involved with another standard that's evolving. You may have heard of it, called QRDA, Quality Research Document Architecture. It's an HL7 standard for specifying both patient-level measure data as well as population or aggregated measurement data. And so we had to step back and learn that and figure out how it is that we actually specify a patient's quality report and how do you aggregate that together to get a measure. Finally, this year, we came back to the place where we could begin to work on the workflow, because all of these underlying profiles, and just in the interest of time, I'm not going to take you in detail through each of these underlying profiles, but I just wanted to show, as you look at the pictures, you see these actors and the transactions happening between them. This is the basic work of an IHE profile, is to boil the problem down to actors and transactions. You see some very simple interactions between one or two, maybe 3 actors at the most, sharing information in a specified way. So all 3 of those earlier transactions, the earlier specifications that we worked out, did this very simple point-to-point. This is the picture for the care plan. So from the public health creator making the care plan, sharing that with the primary care physician, it was a very simple sort of baby step, but we had to get that taken care of. This is the generation of the quality measure report. And we have 2 possibilities. A quality measure report could either be generated by the birthing facility and communicated to a middleman who's responsible for then aggregating all that patient-level information to produce the measure report. or there are certain circumstances where that middle player is really only involved in generating the patient level. They really take the patient experience and they create that patient level quality report. They pass it on to someone else who does the aggregation. We had to support both of those use cases in that scenario. But finally, we got to a place where all of the players in that whole fabric of the newborn hearing detection and intervention space, everyone was in a position where they could get or receive the data that they needed. And this is what set us up to be at a place where we could now start looking at how do we automate that flow of information? How do we do a workflow? So we took on kind of stepping back to the business case and to thinking about the public health mission. We're really trying to identify cases, investigate these cases, manage them over time, evaluate how our management strategies are working out for us, and eventually feed that information back into the guidelines that allow us to make care decisions that will affect and improve care for the population as a whole. So we had to step back and sort of reconsider that business focus and craft a workflow profile from there. So workflow profiles, I don't know if anybody else mentioned this yet about, within IHE there are many domains. And the domains have specialties, like QWERF specializes in quality research and public health. But there are domains that specialize in other technological infrastructure capabilities or perhaps patient care coordination. And what we find in QWERF, because of our spot, is we often need to borrow from the specifications that are developed in these other domains to accomplish what we really need to do. And that's part of the efficiency of IHE, is that it allows specifications to be built in other places where the expertise is there, and then we get this set of Lego blocks that we can combine together for our own purposes. And that's really what we did here. We looked to a profile that was developed in ITI that's called cross-enterprise document workflow. And it was a profile that was developed specifically to allow multiple players who have to share the information flow to record where they are with the task in a document that stands, like I think of it as a checklist, a protocol sheet, something like that, that is available to all of the players so that anyone can look at that sheet and know where we are in the process. Is it time for me to do my task? Do I have the inputs that I need to be able to get started? And if I do, I can do my task and generate my outputs, and then whoever is the next task that needs that for their input can see that it's ready and available for them. So the idea is that the whole workflow can be controlled through this document-based mechanism. So that's what we started working with. And our profile doesn't need to do any of that work of defining that. That came to us ready to be utilized. All we have to do is tailor our own workflow document to fit into that. And so we've been working on developing the actors which have the ability to either create one of these workflow documents, consume one of these workflow documents, or update it, right? Because if you're doing a task and you need to indicate that you've finished, you need to be able to update the document and indicate what task should come next. So all of the actors can perform or initiate these various tasks, and they each have their own set of requirements around input and output documents. One of the things that's different about this profile, other than the one actor that is the repository that collects all these documents, all of the other actors look the same. They are all, in terms of their technological capability, a workflow actor simply has the ability to either create a workflow document, consume a workflow document, or update a workflow document. We're all the same. All the actors are the same that way. And then they may create or consume various different input and output documents, and they might perform certain tasks. So it's been a bit of a challenge to kind of wrap our heads around this, because I'm sure every other presentation up until this point has started with very specific named blocks, and these are actors. But in our case, the actors have a very generic kind of flavor to them as a workflow participant. What you focus on to find your way through is not so much the actors, but the tasks that need to be performed. And so in our case, it's pretty simple workflow. We need to do this hearing screening study. Once that study is done, we need to develop the early hearing care plan. And then that plan becomes available for ongoing update. The update happens as the care manager decides whether or not additional care, like a referral, would need to be done for a baby that perhaps failed their hearing screening. They need to be sent to an audiologist for special testing or treatment. And then it cycles back around to update that care plan again. It's a pretty straightforward workflow. There is an orthogonal workflow that kicks off at the same time as that screening gets done. So each time a baby's screening is done, we are at the same time trying to measure that, keep track of that quality measure. And so the patient level information that's needed to calculate and to confirm whether or not the screening was done, whether it was done on time or not, that information can kind of begin an alternate workflow that kicks off right from there. And so we see that at the point that, like, the baby is discharged from the hospital, we can generate that patient level quality report. Those can be sent to someone who can aggregate that information over a period of time, the reporting period, so that they can generate a quality measure for that population. And then the information can be studied as evidence over whether the care guidelines is achieving the results that they'd hoped for. So we have a correction loop, an improvement loop for the quality of our public health programs that way. So what we're finding in the process that the state that we are in, like the gentleman before, we are in the volume 1 preparation right now. And what we are finding is that the devil is in the detail of defining the tasks. And so over the meetings today, we're working hard at figuring out what these tasks are. We've noticed that our tasks are very similar to sets of tasks that have already been defined in other workflows. And this is one of the realizations that we've come to, is we're seeing an opportunity for modularity in the way that this standard is evolved. I'm actually going to go back to this slide. Oh, can we go back? This slide here, where I've colored 2 of the tasks in yellow and purple. There's already been work on how to do a workflow to request a study. It includes requesting a study, scheduling the study, performing the study, and completing the study. And so because a workflow has already been developed to handle the sequencing of events, the flow of data in and out to handle that, the EDI profile developers are saying, how can we not re-specify any of that, but make use of a base that's already defined? That's really good for interoperability, because any time that you can build upon things that are already defined, it just means that there's that much more opportunity that stuff that already works will keep working in newer environments. So everything that we put in place around how to do a study and the steps of that workflow, we are trying to learn how to call a workflow from our workflow. And it's an evolutionary process, and we don't know how to do it yet, but we're working on it this week. And when we figure that out, what we'll realize is that not only will we be able to chain in the workflow definition for doing a study, but we will then chain in the workflow for doing a referral, because another group has already written that workflow as well. And now we will end up with a public health workflow where we really are only contributing one new task about how to really create that care plan, and the task for the quality measurement, because nobody else is doing that yet. But once we get this done, then we'll be utilizing theirs, building a more complicated thing based on these foundational building blocks. And when we get done, our workflow may fit someone else's workflow. And each time we come along and do another one of these, we're finding that you'll be able to build upon the fundamental pieces. And taking on a really big piece of work that seems complex, like a workflow profile would, begin to be easier, because you can examine the parts that have already been developed, see how you can use them to put your own workflow together, and then only have to build out maybe one or two more parts and combine it together. So that's really what's novel about what we're doing, and just ultimately it's going to be a process that allows us to not to just have stationary standards, but to actually orchestrate how they flow together to accomplish this public health goal with the use of clinical care data.